Hi, this is Dr. Stanley Kim again. I'm still working at North Hawaii Community Hospital. Today we will discuss bladder cancer. People may not know bladder cancer is not an uncommon cancer. Especially in men, it's the number 4, only after prostate, lung, and the colon cancer. Depending on the depth of invasion, the treatment is sharply different. For example, if the tumor had invaded the muscle layer of the bladder, patients need to have a surgery to remove the bladder called the cystectomy. But even after cystectomy, bladder cancer often recurs. So now we give chemotherapy before and the immunotherapy after the surgery. Even with metastatic disease, the newer treatment like immunotherapy or target therapy provides the newer hope to those patients. And for patients who cannot have a surgery for any reason, like old age or underlying medical conditions, breast preservation treatment is now available with a pretty good impressive results. We will discuss more in detail, and thank you so much. As I mentioned earlier, bladder cancer is not uncommon. It's more commonly seen in white men with a median age at diagnosis 73 years. So you may say the bladder cancer is the cancer of elderly white men. Among various types, urothelial carcinoma is the most common. Other types are squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and the carcinosarcoma. The squamous cell carcinoma, in fact, is the most common bladder cancer type worldwide, particularly in Middle East and Africa due to high prevalence of schistosomiasis of the infection. Please look at this picture. Urine is formed in the kidney and drained through renal pelvis, ureter, and arrive in bladder. Please look at the opening of the ureter. Those two ureters are opened in the upper posterior part of the bladder. And this triangular area made of two ureters openings and the bladder neck is called trigone. The bladder cancer most commonly occurs in the trigone area and the bladder neck. I guess those are constantly exposed to the urine carrying some carcinogen. And this bladder cancer is spread through the lymph nodes, first in the pelvic lymph nodes, including iliac lymph nodes, external, internal, and the common iliac lymph nodes, and then move up to para-aortic and pre-aortic lymph nodes. They also frequently involve the inguinal lymph nodes. Cigarette smoking is the most common cause. And there are some controversial issues of hair dyes which contain aromatic amines. So you can see more bladder cancer in hair stylist, hair color dyeing stylist. And pioglitazone, Actos, the anti-diabetic medicine, may increase the risk of bladder cancer. It should not be used in the patients with bladder cancer. The most common sign of bladder cancer is painless hematuria, either gross or microscopic. But don't panic. Microscopic hematuria is mostly caused by benign etiology like a UTI or stones. Symptoms of UTI like frequency, urgency dysuria, bacteriuria can occur, but they are less common. Mostly occurs in carcinoma in situ. Urinalysis has to be of fresh specimen. Urine cytology is used as an adjunct to cystoscopy. It's good to detect high-grade urothelial carcinoma or carcinoma in situ, but it's not sensitive for low-grade papillary tumors. When you have a patient with hematuria, what would you do? The American Urological Association recommends cystoscopy and the CT or MRI of abdomen and pelvis for high-risk patients. Who are those high-risk patients? Elderly patients, age over 60, heavy smoking, more than 30 pack year history, and many red blood cells or gross hematuria. Intermediate risk patients, female age 50 to 59, male 40 to 59, urine RBC 11 to 25, or 3 to 10 on repeat urinalysis. Those patients need to have a cystoscopy and the ultrasound of the kidney. When they are low risk, like a female age less than 50 or male, younger male age of less than 40, never smoker, or very few red blood cells in the urinalysis, then you just repeat the urinalysis in 6 months after discussion with the patients, or immediate cystoscopy and the ultrasound of kidney. Cystoscopy is the most important for diagnosis and the staging. It's done in the office using a flexible cystoscopy. Please look at this picture. A urologist introduced the flexible scope to the bladder and watch the lining of bladder in the screen. When they find some suspicious lesions, then biopsy or resection is done. And at the same time, cytology with the saline bladder wash specimen is obtained. If the urine cytology is positive but cystoscopy found no suspicious lesions, then blind biopsy of multiple areas, including the prostatic urethra, are done. And the imaging study, CT or MRI or retrograde pyelogram, has to be done to rule out a second primary lesion in the upper tract. Fluorescent cystoscopy using aminolevulinic acid instillation 1 hour before cystoscopy makes tumor photosensitized and make it visible under blue light, so it can detect more tumors. Urine for fish, the generic Eurovision, is often done nowadays. It's more sensitive than cytology, especially for low-grade tumor. It detects the chromosome abnormalities commonly seen in the urothelial cancer. It may be helpful in equivocal cases like atypical cells in the cytology. However, urine biomarker, urine for fish test, should not be used in place of cystoscopic examination. Once the diagnosis is made by office cystoscopy and the urine cytology, then you need to resect the bladder cancer. It's done by TURBT, standing for transurethral resection of bladder tumor. TURBT is usually done under general anesthesia. Under general anesthesia, bimanual examination of the bladder is recommended. For TURBT, mostly rigid cystoscopy is used, and you resect those the tumors by electric knife. And the bimanual examination is done before and after. The urologists say when the tumor invades the muscles, you can actually feel the something in the bimanual examination. For imaging studies, CT scan of abdomen and pelvis with and without contrast, including delayed image to check the collecting system, which is called the CT urogram, is the choice of study. But small tumor less than 1 centimeter in size may not be shown. It cannot differentiate depth of bladder invasion. For more accurate assessment, MRI is better than CT scan. After tumor resection, TURBT, CT may not distinguish inflammation or edema from extravesical tumor extension. It's not sensitive to detect for lymph node involvement, only about 60% sensitivity. For muscle invasive tumor, CT chest is included, but not indicated for non-muscle invasive early stage of bladder cancer. As I said, MRI scan with IV gadolinium is better than CT in detecting superficial or multiple tumors, especially in the dome and the trigone and the extravesical extension. Ultrasound is not useful for bladder cancer, but it helps in evaluating upper tract like a kidney or renal pelvis. IVP, intravenous pyelogram, is not much done anymore, but it's still good in detecting small lesions in the ureter and the renal pelvis. If the patient is allergic to IV contrast or have a renal failure, then retrograde pyelogram is done. Inject the contrast into the ureter during the cystoscopy, so you don't give contrast intravenously. Bone scan and the MRI scan of the brain is done only for suspicious symptoms and signs. PET CT scan is better than CT scan for lymph node metastasis detection, but the sensitivity is still not optimal, so it is not routinely used unless lymph node metastasis is suspected. Now let's stage bladder cancer. I like to mention that the fact whether the tumor invaded muscle layer or not is very important to know, because patients with a muscle invasive tumor needs to have their bladder removed surgically. Please look at this picture. TA is a papillary cancer having finger-like projection from the lining of the bladder, mostly non-invasive and low-grade and relatively benign. Next stage is TIS. It's a carcinoma in situ. Unlike carcinoma in situ of other cancers, this is an aggressive tumor. It's a flat tumor, very hard to see during the cystoscopy, and almost always become an invasive tumor. So we actually consider it as an invasive tumor and treat it as such. T1 tumor invades the lamina propria and the submucosa, but not the muscle layer. T2 tumors invade the muscle layers, the detrusor muscle. T3 invades even further to perivesical fat. And the T4 even involves the adjacent organs like a rectum or vagina or pelvic wall. For lymph node assessment, surgeon needs to pick at least more than 12 lymph nodes. T1 means a single lymph node metastasis in the pelvis. T2 means more than one, but still lymph nodes confined in the pelvis. T3 lymph node metastasis means it involves the common iliac lymph node metastasis. And when the lymph node metastasis went beyond the pelvic area, like a para-aortic or inguinal lymph nodes, then it stages M1A, beyond the iliac lymph nodes. And the M1B means non-lymph node distant metastasis, like a liver, bone, lung. And let's see the stage. TA-N0M0 means 0A. TIS is a 0IS. T1N0M0 means stage 1. T2, T3, T4, those are all muscle invasive tumors. About 3/4 of all bladder cancer are non-muscle invasive, but still 25% are muscle invasive disease. How to take care of non-muscle invasive disease? Intravesical therapies are used using either chemotherapy drugs or BCG. As this picture shows, this chemotherapy drugs or BCG is directly instilled into the bladder using the urinary catheter. Which patients need to have a chemotherapy drugs or BCG, depending on the risk of the tumor. European Association of Urologists stratify the risk of non-muscle invasive tumors into three categories: low risk, intermediate, and high risk. Low risk tumor is a solitary low-grade papillary Ta tumor, small, less than 3 cm, and no carcinoma in situ present. As I mentioned earlier, carcinoma in situ is aggressive tumor. High risk is either carcinoma in situ or high-grade papillary tumor, Ta. Also, low-grade Ta with multiple lesions, recurrent tumors, or large, bigger than 3 cm belong to high-risk tumor. Intermediate risk are belong between those low and the high risk. So the low-risk patients just use the chemotherapy, either mitomycin or gemcitabine, just a one-time installation around the time of the TURBT. But intermediate risk or high-risk patients usually need a BCG solution installation. The BCG is a live attenuated Mycobacterium bovis bacteria. It triggers local immune anti-tumor response by macrophage and the CD4 T-cell infiltration. It increases interferon gamma expression and elevates cytokines in the urinary tract. I also want to mention that frequently patients need to have a repeat TURBT within 6 weeks. For patients who had an incomplete initial TURBT or high-risk tumor, pretty much patients with this high-risk tumor need to have a repeat TURBT to make sure all the tumors are resected. If the muscularis propria was not included in the initial TURBT specimen, that means the TURBT was not adequately done. So patients need to have a repeat TURBT. As I mentioned, the low-risk tumors need to have a single intravesical therapy with a chemotherapy just once, immediately after TURBT in the operating room or within several hours. Intermediate risk tumors need to have an induction intravesical therapy with a BCG every week for times 6 consecutive weeks, starting 2 to 6 weeks, usually within 4 weeks after TURBT. And then they need to have a 1 year of maintenance BCG installation, intravesical therapy every week for 3 consecutive weeks at months 3, 6, 12. For intermediate risk tumors, chemotherapy can be used alternative to BCG. But high-risk tumors need to have more treatment. After induction intravesical BCG every week for 6 consecutive weeks, maintenance therapy for 3 years is recommended. What about the side effect and the complication of BCG? This is live bacteria, atypical Mycobacterium bacteria. It can cause bladder irritation, mild fever, malaise for about 2 days. But it also can cause acute and chronic infection, which need to be confirmed by positive culture or positive acid-fast bacillus smear stain. Early onset infection usually associated with the systemic symptoms like fever, pneumonia, even sepsis, biliary TB. Delayed onset infections are more local symptoms like urgency, urinary obstruction. If they have a BCG infection, the patient need to have an anti-TB therapy with a triple drug for at least 6 months, then double drugs thereafter for about 6 months. To reduce the risk of infection, you need to avoid the BCG to patients with a traumatic catheterization, active cystitis, or persistent growth hematuria following TURBT. And the contraindications are immunocompromised patients or patients with autoimmune disease on tissue necrosis factor antagonists like a Humira or Remicade treatment. Low dose of BCG is as effective as a regular dose. And I would like to mention that there are one report that statins, like a cholesterol medicine, may inhibit anti-tumor effects of BCG. So it should not be used with the BCG intravesical therapy. But there are some indications for cystectomy, removal of bladder surgically for non-muscle invasive disease. Those are people who are unable to completely resect all visible cancer despite multiple repeated TURBT, or male patients with a carcinoma in situ involving the prostatic duct because TURBT cannot reach that area. Pure squamous cell or adenocarcinoma histology. A T1 tumor with a lymphovascular invasions because they have a higher risk of recurrence, so often they need to have a cystectomy. Variant histology like a micropapillary sarcomatoid or small cell carcinoma of the bladder. T1b tumor, which means deep involvement of the lamina propria, may need to have a cystectomy depending on the case. Or patients who did not respond to BCG intravesical therapy need to have a cystectomy. What is the cystectomy, radical cystectomy? For men, it removed the bladder and the seminal vesicles and the prostate. In women, it involves the resection of the bladder and the urethra, most of the urethra, and the uterus, ovary, fallopian tubes, and the anterior parts of a small part of the vagina. How to take care of muscle invasive bladder cancer? Radical cystectomy and the bilateral pelvic lymphadenectomy is the standard of care, which means surgeon remove the bladder with the prostate, ovary, fallopian tubes, etc., along with the lymph nodes in the pelvis. Well, because relapse is common after cystectomy, neoadjuvant chemotherapies are introduced, meaning chemotherapies are given before surgery, and it was shown to lower the recurrence rate and improve the survival. How we do that? After 2 cycles of neoadjuvant chemotherapy, CT scan is done to assess the response. If the tumor shrank, then complete the neoadjuvant therapy for 3 to 4 cycles. If disease progressed, then immediately send the patient to the surgeon for a cystectomy. Then surgeon performed the radical cystectomy and the pelvic lymph node dissection. Then pathologist examined the resected surgical specimen to check if there are residual tumors still remaining in the bladder or even in the lymph nodes. If the tumor still found, muscle invasive tumor is found, like a T2, T3, T4, or lymph node metastasis, then adjuvant immunotherapy with the nivolumab up to 1 year is indicated. It lowers the recurrence rate and also improves the survival. What if the patients did not have neoadjuvant chemotherapy? Some patients go straight to surgery. Still, adjuvant nivolumab immunotherapy is indicated for high-risk patients with a tumor T3 or 4 or N-positive lymph node metastasis. I want to mention that venous thromboembolism, DVT, risk is high during neoadjuvant chemotherapy, so anticoagulation prophylactic therapy is indicated. For example, Levanox or a small dose of Eliquis, but not the warfarin. Warfarin is not very effective in this case. I briefly want to mention the neoadjuvant chemotherapy protocol. Most commonly, we do either GC, gemcitabine, and the cisplatin, or dose-dense MVAC, methotrexate, vinblastine, adriamycin, and the cisplatin. Dose-dense MVAC is better tolerated with the pegfilgrastim injections. Classic MVAC is pretty toxic, so it's not commonly used for clinical lymph node negative disease due to high toxicity. But for patients with a lymph node metastasis already, classic MVAC is preferred. Carboplatin is generally inferior to cisplatin, but combination of carboplatin and gemcitabine have shown a comparable survival rate with other cisplatin-based chemotherapy. Cystectomy means no bladder, so the surgeon have to make a urinary diversion system and a new bladder. There are three major subtypes: ileal conduit, Indiana pouch, and the orthoptic neobladder. In ileal conduit, the surgeon take a small segments of ileum, and which is connected to the ureter, and then the one end is used at the stoma, so the urine is constantly drained, and so the patients need to have a urine collection bag. So it's an incontinent urinary diversion, but it's a least complicated procedure. In Indiana pouch, the surgeon have to make a urinary reservoir, hopefully accommodating 500 ml of the urine. And then at the one end is a continent system having a valves or so. And the patients use the catheter to empty the reservoir. Orthoptic neobladder is more natural system. Surgeon make a nice neobladder connected to the ureter on the upper part, and down below the urethra is connected. Then how you urinate? The patients have to exert making a Valsalva maneuver. Then urine comes out. Usually continent during the daytime, but patients may have to use the pad during the nighttime when the incontinence is more frequent. Usually done in men because the woman has a very short urethra. When the patients are poor candidate for radical cystectomy because of old age or comorbidity, or refuse the cystectomy, then bladder preservation treatment is used. It involves the trimodality therapy with the TURBT and the concurrent chemotherapy and the radiation therapy. You have to make sure patients do not have metastatic disease before considering this bladder preservation treatment. So you need to have an MRI scan of the brain, and often need to have a PET CT scan. It's suitable for T2 or TA disease. Very advanced disease is not very good for this treatment. And the tumor has to be single, less than 6 centimeters, and no cancer-causing hydronephrosis, and the absence of extensive carcinoma in situ. If the above conditions are not met, the risk of recurrence is high, so it's not a good candidate for bladder preservation therapy. The trimodality therapy protocols include the maximum TURBT. Patients need to have a repeated TURBT, and then concurrent chemoradiation therapy, usually cisplatin or 5-FU and the mitomycin. After 40 to 50 grays of radiation, then consolidation radiation therapy is given if the tumor is completely gone. If there is still have a residual tumor, then patients need to have a cystectomy. What about the results? It's almost compatible with the cystectomy. Complete remission rate was over 70%, and the 65% of complete remission patients continue to have no disease at 5 years. And the risk of salvage cystectomy, which means failure of this bladder preservation treatment at 5 years, is only 30%. And the 5-year disease-free survival is almost 70%. When the bladder cancer progresses after cystectomy or metastasizes to the distant organs, then cisplatin-based chemotherapy is the first-line treatment. But cisplatin can cause the damage to the kidney or nerve, so the patients must have a good physical performance, e.g. ECGF less than 2, and the good renal function, creatinine clearance over 60, and no significant peripheral neuropathy, hearing loss, or congestive failure. In order to prevent kidney failure from cisplatin, patients often need to have aggressive IV hydration. So the people with the congestive failure cannot tolerate this cisplatin chemotherapy. The regimen used for the treatment is GC, classic MVAC, or dose-dense MVAC. GC means cisplatin and gemcitabine in a 21-day cycle. MVAC is much more toxic. It's more complicated. Dose-dense MVAC is less complicated and less toxic with the filgrastim injection. When the GFR is less than 60 but over 30, then carboplatin and gemcitabine can be used. If the platinum-based chemotherapy is not eligible at all, then paclitaxel and the gemcitabine may be used. Patients whose disease did not progress after initial 4 to 6 cycles of those platinum-based induction chemotherapy, then maintenance therapy with the avelumab improved the overall survival. Especially when the PD-L1 positive, the median overall survival was not reached even at about 2 years. We know the platinum-based chemotherapy is the first choice for metastatic bladder cancer, but there are patients who cannot take platinum-based chemotherapy. Then immunotherapy is an option. There are two kinds of immunotherapy drugs used for this situation: pembrolizumab, Keytruda, and atezolizumab, Tecentriq. Pembrolizumab have a better objective response rate of almost 50% in patients with a PD-L1 CPS over 10. And it is approved for patients whose disease progressed over platinum-based chemotherapy. So it can be used as the first-line immunotherapy and the second-line immunotherapy. Research doctors try the chemotherapy in combination with the Keytruda, but it did not improve the survival, so you don't use those combined therapy. Atezolizumab, Tecentriq, has a little bit lower objective response rate, about 23%, but the interim median overall survival was better at 16 months. So the FDA approved this drug under accelerated program, but it's still awaiting full approval later in this year if study confirms the improved overall survival. However, this atezolizumab has been withdrawn from the indication for patients who progressed to platinum-based chemotherapy. So this atezolizumab can be used as the first-line immunotherapy, but not the second-line immunotherapy. For second-line immunotherapy, you can use pembrolizumab, nivolumab, or nivolumab and the ipilimumab combination immunotherapy, or avelumab. Durvalumab and atezolizumab did not improve overall survival and were withdrawn from this indication as a second-line immunotherapy. What if patients progressed over cisplatin chemotherapy and the second-line immunotherapy with Keytruda or nivolumab? Well, don't be discouraged. We have a very good third-line treatment, which are erdafitinib, enfortumab vedotin, sacituzumab govitecan. It's hard to pronounce. Erdafitinib is a FGFR inhibitor. FGFR stands for fibroblast growth factor inhibitor. About 20% of patients of metastatic urothelial cancer have EGFR 2 or 3 gene mutation or alteration. So we give 8 milligram a day, but it can cause elevated phosphatase levels. So when you measure the phosphate level at 2-3 weeks after the treatment, and if it stays less than 5.5, then increase the dose to 9 milligrams a day. How is the response rate? Objective response rate is 40%. It's not bad. And the side effects are stomatitis, hyponatremia, and the hyperphosphatemia, not severe side effects. And the FDA approved April 2019. Enfortumab is approved last year. It's an antibody against the Nectin-4 chemo drugs conjugate. It can be used regardless of EGFR mutation status. The objective response rate is even better, 52%, but it has more side effects, neutropenia, rash, fatigue, and the 3% death rate due to acute kidney injury or multi-organ dysfunction. Cystoscopy govitecan is recently approved by FDA. It's also an antibody chemo drug conjugate. Objective response rate is about 30%, and the side effects are neutropenia, anemia, and diarrhea. And about 6% are discontinued due to side effect. When I flew from LAX to Hawaii, I saw a wonderful rainbow in the clouds. And one of my colleague doctors reminded me of the Bible quotes. I have set my rainbow in the clouds, and it will be the sign of my covenant with you and the earth. Genesis 9:13. Thank you for watching.